Greetings, everyone from all across the world. My name is Dr. Mojabu Athman Saleh. I'm a neuroradiologist and lecturer at Muhimbili University. I am privileged today to moderate this session, which is one of the lecture series by Health for the World. The talk will be on intracranial pressure dynamics, where we'll look into the radiological differentiation between hypertension and hypotension. And we're honored that this topic will be presented by Dr. Jimmy Lee. Dr. Jimmy Lee is an attending radiologist at Montefiore. He's also an assistant professor of radiology at Albert Einstein College of Medicine. His clinical focus is diagnostic neuroradiology and head and neck radiology. Dr. Lee's research focus has been on demyelinating diseases such as multiple sclerosis and neuromyelitis optica spectrum disorders. In 2015, he also won the Best View Screen Teacher Award from the University of British Columbia. Faculty of Medicine, Department of Radiology, and currently he's the Medical Director of Function MRI at Montefiore Medical Center. He is board certified by the American Board of Radiology with subspecialty certificate in neuroradiology, and is also a fellow of the Royal College of Physicians of Canada. So welcome very much, Dr. Jimmy Lee.
Thank you for the kind introduction. Good morning here from New York City and good evening to Tanzania. And so let's get to it. I had the pleasure of visiting Tanzania in 2017. Was mostly a safari trip. So I did not get to see Dar es Salaam, but I had a very memorable trip there. And I look forward to going back one day and maybe visit some of you. I have nothing to disclose. So overview, I'm going to have three parts to my talk. The first part about intracranial hypertension. I'm going to talk about the imaging findings and particularly about idiopathic intracranial hypertension. The second part of the talk is about intracranial hypotension, talk about the imaging features and discuss spontaneous intracranial hypotension, SIH. Talk about the different forms of spinal leaks and as well as shunt-induced intracranial hypotension. And lastly, we finish with a few cases. I'll give you a few seconds to look at it. I understand the format doesn't allow us to talk directly, but I'll just go through some cases. Okay, so the first part about intracranial hypertension. So you can think of primary and secondary. So primary intracranial hypertension is idiopathic, so we don't know exact cause. We call it IIH, idiopathic intracranial hypertension. Secondary, you have a known cause of ICP. So essentially, you can think of this principle called Monroe-Kelly doctrine, in that the volume of CSF, blood, and brain are in a very rigid space, the calvarium and spinal canal. So their pressure is equalized, so it's in equilibrium. But if you change one of the three components, the other two would have to react to it. So you have a mass, bleed, that kind of thing. Now, so there's a sort of modified Monroe-Kelly doctrine being proposed that the calvarium can be thought of as a fourth component, even though it's a rigid structure. When you have a chronic hypertension or hypotension, there's actually skull findings, calvarial findings. So, for example, in chronic hypertension, you can get partially empty sella, skull-based pittings, and meningeal cells, for example. And whereas in hypotension, you can actually get what's called layer calvarial thickening, and I'll show you examples of that. In terms of causes of increased ICP, you can broadly think of like brain, blood vessel, CSF, and mass. So in the brain itself, if you have cytotoxic edema from stroke, vasogenic edema, blood vessel defective autoregulation, venous sinus thrombosis, for example, hydrocephalus from CSF. You got a hematoma in the brain, tumor in the brain. So very basic principles. Now, imaging characteristics, these are, for example, space-occupying lesions, of course. And always check the basal cisterns, suprasellar cisterns, that kind of thing. Look for shifts and look at the south side, particularly the vertex. And look at the gray-white differentiation, the brain itself for edema. And for chronic changes, look for bone remodeling. So in terms of secondary intracranial hypertension, basically you have a known cause. So these are straightforward. But what shows intracranial hypertension, we'll go through some cases. Here's some examples of trauma. This is a person with a calvareal fracture with an epidural hematoma and some scalp hematoma as well. And so by itself, it's not really large, but you got to be careful because over time, these epidural hematomas can grow and enlarge and cause a lot of increased intracranial pressure. Here's another example. You have a large subdural hematoma, mixed density, causing effacement of the sulci mass effect, right to left midline shift, effacement of the lateral ventricles. So this is another example. Here's a patient with subarachnoid hemorrhage, diffuse throughout the sylvan fissure here and over the convexities. Over time, though, this can cause communicating hydrocephalus. So now the ventricles got bigger, there's transepineal CS flow, and there's also a little bit of bilateral subdural hygromas. So you kind of observe that, so the dynamics change, especially in context of trauma. Here, on the other hand, it's not acute, it's a chronic. So it's a child with a chronic hematoma. And interesting here, you have a subdural convexity hematoma of various different signal. And there's actually thinning of the calvarium on this side relative to the other side. So there's remodeling. Here's the right convexity subdural collection with mass effect on the cerebral sulci. You can see the olfactory groove. Look how big they are. So there's a remodeling of the olfactory groove. And then you can see signs of papilledema. There's flattening of posterior globe, protrusion of the optic nerve head, very tortuous and optic nerve and dilated CSF spaces in the optic nerve sheath. So what about non-traumatic causes? So here, for example, you got patient with noxic brain injury. So you see classical findings, diffuse cerebral edema, loss of gray-white differentiation, effacement of the sulci, as well as ventricle system. Here you can see because of the low attenuation of the brain, what we see here is called a pseudo-arachnoid hemorrhage. So the tentorium here looks dense like hemorrhage, but it's not if you measure it on CT Huntsman units. That's because the surrounding structures are so low attenuation. Same thing with the vessels here. It looks like it's blood, but it's not. Or bleeding, it's not, yeah. And here, another non-traumatic cause is a 15-year-old girl with sickle cell disease. So they can get these spontaneous epidural hematomas. So it's non-traumatic. And so this patient got relief of the epidural hematomas decompressed. And post-op MRI showed resolution of the epidural hematoma. And there was signal changes in the brain in the subcortical white matter. So they didn't restrict or and on MRI. And after a follow-up MRI, it was completely resolved. So we thought this was probably a post-op press. So interesting case. Here's another case, a 50-year-old woman, 8 days headache, right arm weakness. So on-enhanced head CT. It's a dense superior sagittal sinus. So it measures over 70 Hunts per unit. A CTV or CT with contrast showed that the classic empty delta sign, the filling defect. And here's a different case. So someone with a hemorrhagic mass turned out to be a metastasis with the biopsy or the resection. So patient had a resected. This is the immediate post-op CT showing pneumocephalus after craniotomy. And the air goes along the paraphalcine region here. And there's a midline shift, effacement of the underlying sulci. And you can see a bit of a tinting here. There's like some cortical veins here. So I thought this could be tension pneumocephalus, and I told the surgery team about it. And they did a follow-up MRI next day because of the mass, the metastasis. You can see that's increased, markedly improved. Less pneumocephalus, the midline shift is gone. Effacement of the cell size improved. So it's probably an overcall. So on the matter of tension pneumocephalus, essentially that you get these air collections, usually after surgery, and they have compression of the on the frontal lobes. And the frontal lobes are displaced posterior by air, and you can see these bridging veins and give this kind of a tether kind of appearance. So some people have called this a Mount Fuji sign. And so looks like Mount Fuji. And if you're a Lord of the Rings fan, maybe it's Mount Doom. Really doesn't matter. But I think the important is not to overcall it. So the way I approach it is, if I see it, I suspect it, I tell them, but they would then do a follow-up imaging if the patient got worse, and then go from there. Okay, so idiopathic intracranial hypertension, it has different names. So in old days, pseudotumor cerebri, we still use it, in literature, see a benign intracranial hypertension. And essentially, you have signs of intracranial hypertension or intracranial pressures, but you don't find a mass or hydrocephalus. And these are common presenting symptoms, mostly headache, aggravated by a Valsalva maneuver, so straining bowel movements. And one of the most important things about IIH is the visual impact. So visual loss, Fulminant IIH could be a severe vision loss less than 4 weeks. They usually always have papilledema. And so progressive vision loss is one part. The other part could be cranial nerve 6 palsies. And it can also present with tinnitus, vertigo. Now, what's interesting here that they may not present with any of this, but come in with CSF leak, like rhinorrhea or something, right? So patients with no symptoms of intracranial hypertension but have a CSF leak from, let's say, a skull base leak, and you repair the leak, they actually get worse because basically they decompensated and able to remain in equilibrium. And you repair the leak, now they have intracranial hypertension symptoms. They can also present with temporal lobe epilepsy. So because of the skull base defect from intracranial hypertension, they can get a temporal lobe meningoencephalocele, for example. So these are typically among a young age group, at least for the people that we see, and very common in someone who's overweight, BMI greater than 30, and reproductive age women. And there's definitely a large female to male ratio. And there are other things that are not associated with it, not definite cause, but certainly medications, notably tetracycline, vitamin A. They can also be associated with some endocrinopathies, chronic renal failure, and SLE. Now, in terms of diagnostic criteria for the IIH, this is from Freeman criteria. So they can call it definite intracranial hypertension if the opening pressure is greater than 25 CSF and papilledema coexist. Now, for children, it's a little bit higher because normally children have a little bit higher CSF pressure. So the cutoff is greater than 28. You can call it probable IIH when you have an open pressure that's not elevated, but you do have papilledema. You can also substitute papilledema with cranial nerve 6 palsy. So here again, you have increased opening pressure, no papilledema, but you have cranial nerve 6 palsy. So you can think cranial nerve palsy and papilledema as one of the two. Now, in some cases, they said suggested IIH. So you don't have papilledema or cranial nerve 6 palsy. What you do have is elevated opening pressure, and 3 out of the 4 neuroimaging findings here. So empty sella, flattening of the posterior globes, distension of the optic nerve sheath CSF, with or without tortuosity of the optic nerve, or stenosis of the transverse sinus. Okay, so imaging plays a role here in these cases where there's high elevated opening pressure, but no papilledema or cranial nerve 6 palsy. So here we go through the imaging findings typical of IIH. Now the orbits are important, so you got flattening the posterior globes, the optic nerve head protrusion, enlarged optic nerve sheath CSF, and tortuosity, partially empty sella, dural signs stenosis, not thrombosis, stenosis, cerebral tonsil ectopia, slow-like ventricles, and then you can get these skull-based meningocele, or if the brain goes through it, it's meningoencephalocele. You can also get multiple or solitary skull-based defects called Ragnar pits. And sometimes the skull-based foramen might be even enlarged. So these are the best clues, the orbit, and partially empty sella, and venous sinus stenosis. Like the slit like ventricles is classical, but you don't see that often. So here's examples taken from a textbook. So you got a T2 image of the orbit showing the optic nerve head protrusion, flattening of the posterior globe. Here's a protrusion of the optic nerve head, and prominent CSF spaces in the optic nerve sheath. Here on the sagittal view, you see the tortuosity. And post-contrast, if you do them, you may see enhancement of the protruded optic nerve heads and maybe even optic nerve sheaths. And they're bilateral typically. On the sagittal image here, non-con T1 shows a partially empty cella. Now, when we say partially empty cella, it's not completely empty. And this is about tonsil ectopia. So always think of the pituitary relative to the patient's age and status. So in a puberty woman in pregnant age, you know, if 50% or lower, it's considered partially empty cella. Here on a CT with contrast showing stenosis of the transverse sinuses. And typically the stenosis is between the transverse sinus and the sigmoid sinus junction. So here's a case with a 44-year-old woman. Basically has concern for CSF rhinorrhea, so it's clear fluid from the nose, and then got an MRI. And what it shows is that there's this lateral sphenosinus defect with a encephalocyl. So the sphenosinus here is filled with CSF fluid, and there's a brain sticking out into it. So the right temporal lobe is herniating through this defect. So you got a CT, show that indeed the right lateral wall of the sphenosinus is dehiscent, and there's also multiple arachnoid pits. So basically they have a skull face defect, and it's basically a lateral sphenoid malingual encephalocele. Now the same patient, right, has MRI findings suggestive IIH. What are they? They're partially empty cella. And then the post-contrast coronal and axial T1, you can see the stenosis here of the transverse sigmoid sinus junctions. And there's some prominent optic nerve sheath CSF and tortuosity. And the coronal view, you can see that these Meckel's caves are enlarged. So the kind of bilobe appearance, a lot bigger than what you expect. So the important part about the stenosis of the transverse and sigmoid sinus junction is that the question is always, is it congenitally narrowed, or is it because of increased pressure causing the narrowing? So whether it's fixed or it's dynamic, not entirely sure, but what happens is a vicious cycle. So when you have stenosis, what happens, the venous structures upstream to it increases. Now, normally the CSF pressure is higher than the venous side. So there's CSF going to the venous effect. But because of the upstream increased pressure, the gradient decreases. And now the CSF pressure then continues to increase. And then if you have increased CSF pressure, then it can then cause more stenosis of the transverse sinus, sigmoid sinus junction. So there's a vicious cycle going on. This diagram just show you that beyond the skull, you have to think about things that can cause venous outflow restriction. So within the skull, you can think of like displaced fractures on the causing thrombosis of the superior sagittal sinus or stenosis of transverse sinuses, sigmoid sinus junction. But outside of the brain, if you have increased abdominal pressure, thoracic pressure, compression of cervical veins, you can also lead to increased resistance in the intracranial venous system. Okay, so we talk about treatments lastly. So certainly for people who are BMI over 30, weight loss is recommended, and then so this has shown to help. There are medications such as carbonic anhydrase inhibitors like acetazolamide, trade names Diamox here. You can get serial large volume lumbar puncture if they provide relief. Now, if they have to do this very frequently, then a shunt might be better, a lumboperitoneal or VP shunt. There's also been done in our center some dural sinus stenting, and for people with stenotic transverse sinus sigmoid sinus junction with severe pressure gradient. And for preservation of the vision, for cases that require it, an optic nerve sheath fenestration may be done. So this is basically the first part of the talk, and we're going to the second part, which is intracranial hypotension. And so you can also think of primary and secondary. So primary intracranial hypertension is also called spontaneous intracranial hypotension, so SIH. The secondary intracranial hypertension can be like iatrogenic, from LPs, from surgery, trauma, over shunting. Now, essentially, you can think of causes of SIH as spinal leak. So interesting, what I mentioned earlier, scalp-based CSF leaks rarely result in SIH symptoms, right? They're typically secondary to intracranial hypertension. So again, the Monro-Kelly doctrine is the same. Now, because now we have a CSF leak, the other volumes have to increase. And typically it's the venous side because the venous side is most compliant. There's an important concept here I want to talk about. It's called the hydrostatic indifference point. Essentially, if you look at the brain and the spine as a neural axis, and you measure the CS pressure from the brain all the way to the sacral canal, there's a point where it will be equal regardless of your position. So if you're supine, upright, it's the same. So this point called the hydrostatic indifference point is usually located in the lower cervical upper thoracic region around C7, T5. So you can imagine when you stand, pressure above this point will decrease. It's like a water, right? A water column. And the pressure lower below this point and lower in the spine will increase. So this change typically happens, but it's not large enough to cause symptoms of intracranial hypotension. And physiological ICP in the upright position is actually negative to the atmosphere. So one interesting thing is that there's a point also when you measure it where the pressure is zero, and we call that the zero CSF pressure point when you're sitting. And so if you have a CSF leak above the 0 point, it's negative, right? So basically, if you have a relatively negative pressure in the brain, if you have a skull-based defects that's above the zero pressure point, you don't have a CSF leak when your patient's upright. So when you lie down, then you get CSF leak. In contrast, when you have a leak that's lower down in the spine, then the pressure will increase, right, when you stand up. And so the leak will make it worse. And then you get orthostatic headaches because of that. And so it reverses on the other end. Once you lie down, the pressure normalizes, improves the headache. And so that's why when you have a leak in the skull, typically you don't have symptoms of intracranial hypotension. But if you have a leak in the spine, you get the symptoms. So what are the common symptoms? Severe headaches is orthostatic typically. So they get worse headaches standing up, and then when they lie down for 10, 15 minutes, they get better. Sometimes it's pulsatile. They can also sometimes get cranial nerve 6 palsies and stuff like that. Rare, you can get encephalopathy, loss of consciousness. And however, just because the patient don't have that type of orthostatic headache, it doesn't exclude SIH. And opening pressure, although it could be low, a lot of times is normal. So you can't use that as a criteria either. So interesting enough, most of these patients have similar demographics to the idiopathic intracranial hypertension, and usually younger adults, and also a greater female to male ratio. It's also associated with some of connective tissue disorder. It's thought that they have an increased risk of CS rupture through a congenitally weakened dura. So Marfan's, Ehlers-Danlos. Now, what about the imaging characteristics? So there's an acronym called SEEPS. So subdural collection, enhancement of pachymeninges, engorgement of dura venous sinuses, pituitary hyperemia or engorgement, sagging of the brain. So I don't use personally, but this is just an acronym people use. Some people add an extra S for superficial siderosis in for tentorial side. Now, by itself, it's not really a sign of intracranial hypertension, but it suggests that there may be a spinal leak from a dura defect. And then basically on the gradient images, you can see the hemosiderin staining on the cerebellifolia along the middle cerebellar peduncle. So it's thought that maybe there's some tear of bridging veins or something related to spinal diverticulum or something. And they can have symptoms once you reach this state, hearing loss, ataxia, that kind of thing. So the CT findings are very similar, but much more difficult. So things that are observable might be like subdural collections, brainstem sagging. So you definitely do a sagittal reformats for your CTs. Tonsillar ectopia, you can get dural sinus extensions. And this thing called a layer calvar hyperostosis or layer cake skull. So in a normal setting, in a skull versus a diffuse calvar hyperostosis, which you see quite often. The layer calvar hyperostosis show different layers here. And that's been shown in the AJN article that this is maybe associated with intracranial hypotension. Here's some schematics about the differences between the normal and SIH. So normal on the left side, and there's a lot of findings on the right. So I'll go through one by one. And this is from a JAMA article. So distension of the superior sagittal sinus or dural sinus dural venous sinuses enlargement. You can get pachymeningeal enhancement. This is like superficial siderosis. You have a subdural collection. You have a phase supercell cistern, so normal on this side, right? You can see that's a phase on the right. You can also get enlarged intercavernous sinus. So there's actually a venous channel connecting the two cavernous sinuses on both sides. Normally, you don't see it, but in the case of intracranial hypotension, you can sometimes see it. You can enlarge pituitary engorgement or hyperemic. On a sagittal view, you can have effacement of the supracella cistern. There is effacement of the pre-ponting cistern and a decreased mammaloponting distance. So if you measure a distance from mammary body to the top of the pons, it's decreased compared to a normal side here. And you can get a cerebellar tonsil ectopia, or low-lying cerebellum tonsils. So here, example here, we can go through the seeps. Here's a phase supracella cistern. You can see the optic hyson draping on top of the pituitary. There's a sagging midbrain, pontomesencephalic distance or angle is decreased, mammaloponting distance is decreased, pre-ponting cistern distance decreased. You can see the fat looking pons. This corpus callosum splenium is sagging. Here, the cerebellar tonsil is low-lying. And on the axial T1 post-contrast, you can see a pachymeningeal enhancement, subdural collection, and engorgement of the sagittal sinus. And so these are seeps kind of thing, SE. Here's a P for enlarged pituitary, and here's a sagging midbrain as well. And last thing here, just to show you that just diffuse dural enhancement. Sometimes the dural enhancement can even extend to this spinal canal. Now, there are actually quantitative measures, like I've mentioned those distance, and people have give numbers. So if you measure a distance between the mammary body and the pons, called a mammaroponting distance, below 6.5 is considered abnormal. And then same thing with the angle, the pontomesencephalic angle. You take an angle between the midbrain and the pons. So abnormal would be below 50. Depending which literature, report a little bit different numbers, but very similar. And interpeduncular angle can also be measured. And so why are we doing this? Essentially, when you're looking for clues to it. And so what are the best clues? So they have called this classic imaging quintet, the top five, I guess. So downward displacement of brainstem, so brain sagging, diffuse dural thickening or enhancement, pachymeningeal enhancement, distended dural venous sinuses or veins, subdural hygroma or hematoma, and a gorge or enlarged pituitary. Now, having said that, you can have only two or three and it's still okay. You don't have to have all five. It's actually rare to have everything though. But in terms of the bilateral subdural collections, it happens about 35% of the time, and most of it is hygroma, but you can also get hematoma. So the thing is, if you see someone with bilateral subdural hematoma, don't, even with a history of trauma, don't just say definitely trauma, right? Is there something else? There are serious complications. I won't go too in detail of this. So you can actually get a coma and then these very interesting frontal temporal dementias, superficial siderosa I mentioned already. And so these are more uncommon but serious complications. Now, there's a scoring system to help you to decide if you can find a CSF leak. So this is not to diagnose it, but if you have someone with SIH and you want to know where is the leak, and if I do a spine imaging, can I find the leak? Then the scoring system helps. So the Burns system is from University of Bern in Switzerland. And basically there's a point system, 2 points for any of these findings and minor for any of these three. So these things we've talked about already, but let's show you what it looked like. So for example, on the suprasellar cistern, if it's less than 4 millimeter, 4 or less, you get 2 points. Pontal mammary distance, if it's decreased than 6.5, you get 1 point. Pre-ponting cistern less than equal to 5, you get another point. And the other ones are pachymeningeal enhancement, distended dural sinuses, and subdural collection. So you can add them up and then 0 to 9 points. Maximum is 9, minimum is 0. It's basically a 3-tier system. You have low, intermediate, and high. So when you have a high, you're basically saying that imaging of the spine is most likely to find a leak. So through myelogram or MRI, that kind of thing. And whereas low, you're not likely to find something. So just to be sure, this is not used to diagnose SIH, right? It just gives you a likelihood of a positive spinal imaging. So particularly these are young patients, right? So you think about it, like someone who is like in their 20s, 30s, you don't want to keep doing a lot of CT to increase the dose, doing a lot of myograms, for example. Now, what about the spinal findings? So typically you have these long, extensive epidural collections. So we call it spinal longitudinal epidural collection. So they call it SLEC, SLEC. You may see the dural defect. You may see meningeal diverticulum, perineal cyst. And sometimes you can see engorged venous plexus, venous veins. And occasionally spinal cord signal abnormalities. Now, in terms of spinal CSF leak, there's 4 types, and we'll briefly go through them. Type 1 is a dural tear, and the most commonly ventral and in the thoracic spine. And they usually they're secondary to a disc osteophyte complex or calcified disc protrusions, and they're responsible for 40%, so a large proportion of them. A type 2 you can think of as a lateral leak, and then they're associated with a meningeal diverticulum, and there's a defect where the nerve root sleeve is, and then a leak from there. They're typically in the lower thoracic as opposed to the upper thoracic. And here's about 17% of the case. Type 3 is a CSF venous fistula, and it can be associated with diverticulum. And in terms of numbers, this is probably underdiagnosed because these are hard to detect. So on MRI, regular MRI, you're not typically able to see them. There's no epidural collection. And so these numbers have been increasing over the years because people are getting better techniques. And type 4 is kind of very rare. It's called indeterminate. Sometimes people think it's a distal nerve root sleeve. So because it's distal, you're not going to get any collections in the spinal column. So you can think of type 1 and 2 are typically younger age group, younger adult, and type 3 typically middle age or older. These are schematics showing the 4 types. So type 1, SLEC positive, just means that on the MRI, for example, you can see a epidural collection. And they can divide to ventral lateral tear, but basically it's a dural tear. Type 2 is that association of the nerve root sleeve and diverticular leaks. So this is also positive on MR spine imaging. Type 3 is typically negative. You don't see the epidural collection on the MRI, but it's basically because it's due to a CSF venous fistula. And then type 4 is also negative, but this is very rare. Now, in terms of spine imaging, what type of modality, right? MRI is definitely imaging of choice. Try to use a fat sat sequence, ideally 3D. 2D is fine too. Dynamic CT myelogram, this is done when the patient is on the CT and you inject them. So you position the patient first. And usually you inject them and you scan them like 2 minutes later. Like you don't take a long time. So you want to see the part where it is a site of a leakage. Digital substitution myelogram, this is for scopic technique, but the digital subtraction helps remove the bony structures and stuff like that. It has the best temporal resolution, but you need definitely a good experience doing this, and it's useful for looking for fistulas. And nuclear medicine can be done too with intrathecal indium DTPA. The spatial resolution is very poor though, however. So here's an example of a SLEC on the MRI. So you can see a T2 sagittal of the spine. There's the thin ventral and dorsal epidural collection. On the fat sat sequence, same thing at this level here. You can see the ventral epidural collection. This is the dura here, the dark line, the thecal sac, and the dorsal. And this patient here got a lot of degenerative changes. Had a CT done, a CT myelogram, and there's a dysosteophyte complex there with a small leak. This is actually not a leakage, it's very dense contrast. And on the axial, you can see that it's intrathecal. On this level, though, you can see that there's epidural collection. So this is a type 1 ventral leak. And here's an example of a type 2 CSF leak where you have, again, ventral and dorsal epidural collections. Here's a thecal sac, and there's associated diverticulum here. And here's a schematic showing that here's a diverticulum with a leak around it. And there's other diverticulums that are elsewhere. So what about treatment here? So patient with symptoms, they can get a non-targeted epidural blood patch and then see how it goes. If you know exactly where the leak is, or after multiple failures, you can get a targeted epidural blood patch. In our center, we also use fibrin glue patch. This is basically using fibrinogen and then combined with thrombin. And in some cases, like especially fistula, surgery may be an option. Now let's talk about other types of CSF leaks. These like, for example, trauma, iatrogenic, the LP, spinal surgery, and then some rare cases of CSF to lymphatic fistula. Now this is one of our cases where we have a patient with a known AVM in the posterior fossa and has a shunt placed in here. You can see the shunt tip. It's the cavum septum pellucidum and stuff like that, but essentially this is the baseline image. So patient has a shunt in because the posterior fossa has an AVM with mass effect and stuff like that. So follow-up imaging show that you have increased subdural collections. The ventricles are no longer dilated relatively, but there's pachymeningeal enhancement and engorgement of the transverse venous signs. So basically you have like over-shunting kind of a phenomenon here. Now, last point, remember we're talking about all these low-lying cerebellar tonsils, right? So this is distinct from Chiari-1 malformation. Now, Chiari-1, there's no universally agreed distance, but typically some reported greater than 5 or equal to 5 or greater cerebellar tonsils below the foramen magnum. So I usually use 6 millimeter just because you're not, it's probably easier. But not just the cerebellar tonsil is low, but the shape of it is important. It has to be a peg-like shape instead of the rounded shape that normally is. And you have the obliterated CSF spaces of the foramen magnum, and as well as alter CSF dynamics. You may see a syrinx in the cord in the cervical spine typically, and it can be associated with skull base abnormalities as well as cranial cervical junction abnormalities. And the headaches are typically reported as cervical, occipital cervical in the back. Now, if the patient does have syrinx, they may have like limb weakness, sensory deficits, spasticity, for example. Here's a typical, again, textbook kind of appearance of Chiari-1 malformation. There's a pre-syrinx in the signal in the C-spine. Here's a low-lying peg-shaped cerebellar tonsils. And here, again, a different patient with low-lying tonsils, peg-shaped, effacement of CSF space of foramen magnum with a syrinx. So there's a big list of Chiari-1 versus spontaneous intracranial hypotension. Just to go back to make sure you look at this, see the brainstem, midbrain pons. There's no brain sagging here, right? The memory ponting distance, suprasellar cistern. So basically, essentially, is in Chiari-1, there is no brain sagging kind of appearance. Everything is normal. Whereas SIH, you have all these findings that we talked about earlier. So these are the main thing. So you don't want to diagnose someone with SIH as KRE1, for example. So that's it. So we're going to the last third part of the talk. We're talking about some cases. So here's an example of case 1, sagittal T1, T2 axial. So what do you see? I give it a few seconds. So this patient has no brain sagging. The cerebral tonsil is a little bit low. We measure like 3 millimeter below the foramen magnum. And there's no effacement of the retrocerebellar CSF space. So this is just an isolated low-lying cerebral tonsils. What about this case? Cerebral tonsil low-lying, peg-shaped. Foramen magnum is very tight. There's no brain stem sagging, right? See the midbrain, pons, and mammary body distance. Here's a different patient, same thing here. Low-lying tonsils, effacement of the retrocerebellar or tonsillar CSF space. So this is basically KRE1. What about this patient, case 3? A lot of findings here on the sagittal T1. You got your low-lying torcula, low-lying cerebral tonsil, very shallow posterior fossa, right? Corpus callosal dysgenesis, large massa intermedia, tactile beaking, thin elongated fourth ventricle. You got interdigitation of the gyrus with the fenestrated falx, towering cerebellum. This is a KRE2. Another low-lying cerebral tonsils. So what do we see here? Remember the imaging findings, from the burn score and all that, right? Here's a phase suprasellar cistern, kind of plumpy pituitary, sagging brainstem, lower-lying splenium of the corpus callosum, low-lying cerebellar tonsils. Coronal T2 shows the subdural fluid collection. Post-contrast shows pachymeningeal enhancement and a little bit distended sagittal sinus. So this is intracranial hypotension. Case 5. So again, cerebellar tonsils a little bit low-lying, but there's a partially empty sella. And axial T2 image of the orbits show the flattening of the posterior globes, a little bit tortuous optic nerve, and increased CSF spaces, as well as the empty sella here. On the post-contrast T1, you can see the stenosis of the transverse sigmoid-sinus junctions, and MRV confirms it as well. So this is a case of idiopathic intracranial hypertension. And last case here, patient have a diffuse cerebral edema. There's effacement of the sulci, very tight basal cisterns, ventricles are effaced. And then there's restricted fusion throughout the gyriform cerebral hemispheres, deep grade white structures. There's cerebellar tonsillar herniation, crowding of foramen magnum. So this is basically intracranial hypertension from anoxic brain injury. Okay, so lastly, this is a summary slide. So when you have idiopathic intracranial hypertension or findings of it, you have to definitely exclude other causes. And try not to overcall tension pneumocephalus. Again, I would talk to the clinicians, let them know about it, but it's a clinical diagnosis. Rarely, all the classical clinical and imaging findings of SIH present at the same time. So having something not there doesn't preclude it. And don't misdiagnose intracranial hypotension or hypertension as KRE1s, because all three of these have low-lying cerebral tonsils, right? KRE1 doesn't have the brain sagging. The burn score can be used to predict the likelihood of finding a CSF leak in the spine. And spinal CSF leaks are more likely to be seen with type 1, type 2 leak. And lastly, skull-based CSF leaks from hypertension usually don't result in symptoms of SIH. And I just want to end my trip in 2017. Some photos from my trip at Serenera airstrip when we left in Serengeti. This is me taking photos. Unfortunately, we crashed. We flew into a storm. This is from Dart Post. We hit 3 trees, and the third tree stopped us. And this is the accidental report. The aircraft impacted the tree, causing serious damage to the engine and forward fuselage. Right-hand wing broke away from the fuselage. 2 of the passengers and pilot received minor injuries. So of the 2 passengers, one of them is my girlfriend. And this is my seat and broken glass. Not a scratch on me. So I did not have increased intracranial hypertension, but my blood pressure and heart rate was very high that day. Later on, took more photos. I was able to get an aerial photo of the crash site, and using Google Earth, I can find the location. So the airstrips here, we crashed around here about 1.4 kilometers away. And it's with my mother, after we being rescued, we're just saying we're happy to be. So I would love to go back to Tanzania one day, but I will not be on a small plane. So anyways, so that's the end of it. I'm happy to take any questions, comments.
Right. Thank you very much, Dr. Lee. That was quite an enlightening topic. We had a lot to learn, and very sorry for the accident. So welcome, everyone. Please feel free to drop down any questions you have in the Q&A box, and Dr. Lee will be more than happy to take them. Dr. Lee, there is a question here. So you've mentioned a number of diagnostic criteria for diagnosing idiopathic intracranial hypertension, and that entails both clinical and imaging findings. But understanding in most of our clinical setup, we don't even get the clinical history in that detail. So I'm just wondering, out of the imaging findings, what will be the most reliable to account for IAH?
Yeah, so good question. So because a lot of it is clinical, but remember that papilledema itself, although clinical, we can see that MRI of the orbits. Now, we don't always order orbits because depending on the ordering physician, but even on a regular routine MRI brain, you can see, especially on axial T2, the orbits, the posterior globe flattening. And I always say 3 things that usually I'll look for, right? The posterior globe flattening, optic nerve sheath, CSF, tortuosity. If you don't have a good sequence that can see it because a dedicated orbit was not ordered, look for a partially empty cella. But partially empty cella is very common by itself, right? So by itself, you can't just call that. You have to put it together. I would say dural sinus junction stenosis is more reliable. And again, you need a good technique. In our institution, our post-contrast T1 is 3D volumetric slices. You can look at them very well. So we don't need an MRV separate order, right? So those are the ones that I typically look at. So usually, from my experience, the request is papilledema or headache, something like that. And I look at the things that I've just mentioned, and then I'll raise it as a possibility. I don't make the diagnosis. I say suggestive of idiopathic intracranial hypertension, correlate with CSF opening pressure or papilledema, that kind of thing. Sometimes you get a referral from ophthalmologist saying that I see bilateral papilledema, and then they want to rule out other causes of intracranial hypertension. So a lot of times they want to make sure there's no tumor. So instead of pseudo tumor cerebri, you have tumor cerebri or something like that. Yeah. So those are important clues. But if you only have CT to start, right? And CT is a lot harder. And then you look at, is there something like a partially empty cella? Again, globes, depending on technique, you can see whether or not it's flattened or not, or just a little bit more tortuous optic nerve. Yeah. So essentially, I don't say the diagnosis that I made the diagnosis, right? Because there's that criteria. So I was usually tell them to correlate with physical clinical exams.
Thank you very much. Another question is, you mentioned durovenous sinus stenting is usually indicated in case of those patients who have durovenous sinus stenosis. Is there any role for acetazolamide before stenting in those scenarios?
Sure. I think all these non-invasive things should be tried first. So particularly, like I said, there's association with increased BMI in a lot of subjects. And so weight loss is important. Acetazolamide medication, a lot of times we do that first thing. So Diamox, for example. So you can think of progressive, more invasive, so weight loss medication, then something that's like surgical. So some people get serial LPs, so they're not being shunted. But if they have to get LPs like very frequently, it's too impacting their lifestyle, then they may have a shunt placed. And then so stenting, then it's kind of reserved for more difficult cases. And not all centers agree upon the role of stenting. And I'm not expertise in that area, but that's sort of like number 4 or 5 on my list in terms of what to do. You want to do all the conservative stuff first, least invasive stuff first before going to stenting, because there's obviously much more hazard doing stent.
All right. Thank you. Another question is there any particular sequences in addition to the standard T1, T2 sequences for diagnosing SIH?
So SIH, so we're looking for all the what we call seeps in the brain. So a regular MR brain usually has all you need. So particularly like you want to get a good quality sagittal image. So sagittal T1, then you can look at brain stem sagging, cerebral tonsils, supracell cisterns, that kind of thing. So usually that's fine. But remember, like you can also get dural thickening without contrast. You can see it on FLAIR. It might be tricky if it's very thin. So ideally a post-contrast to look for that pachymeningeal enhancement. And depending on the technique, you can also see the venous engorgement better. Yeah. So if I would say anything in a routine brain, you want to have a contrast. That will probably cover most of it.
Thank you very much. So a lot of congratulations from the chat for the lecture.
Thank you so much, Dr. Lee, for an amazing lecture.
Thank you for the invitation. It's my pleasure.
Yeah, I do not see any more questions. Yeah. Thank you, Dr. Mama Jabu, for an awesome moderation.
Thank you. Thank you.
Great. Thank you, everyone.
Yeah.
I'll stop share here.
Yeah, sure
Thank
thing.
you.
Thank you so much. Have a nice day, everyone.
Bye.